So I want to thank everyone for coming, and thank you for the CCTS for inviting me to talk today. So the talk is going to be focused on the use of bioinformatics data to facilitate participant recruitment. So, and I'm just going to start off with a little bit of background just to kind of let you know about why this talk is important. So participant recruitment, as most of us know, is a significant barrier to meeting clinical research aims. About 31% of trials don't meet their targeted enrollment. And in a review of clinical trials, there are about 122 clinical trials that were reviewed in this meta-analysis. 9% of them were halted because of recruitment failure. 47 of the 122 trials, or 41%, had a delay in starting recruitment. And most of the time, whenever there was the delay in starting recruitment, it was because there was a problem with the clinical site, identifying the clinical site, getting commitment from the clinical site, logistical issues along those lines. So what do people do to try to improve recruitment? We all, or most of us probably, have tried some of these in the past. But the most common types of recruitment strategies that were reported in this meta-analysis were the use of flyers. About 21% reported that they tried that mechanism. Frequent calls and visits to the clinical site was another mechanism used by about 12%. People used posters. Some people changed the inclusion-exclusion criteria, which of course that brings on some issues as far as the quality of your study. Presentations to groups, and then different types of resource materials were additional strategies used. So the results of poor recruitment, they can not reach your targeted sample size, and in doing that, of course, the study can be underpowered. There's slow progress towards the goals, which can extend the length of the trial. That can delay the time to actually having clinical impact. It also increases the project cost. And in doing that, it can results in lack of funding to complete your study aims. So out there, how many people have had trouble recruiting participants in your studies? Okay, I figure probably most people. It is definitely a challenge, and probably why you're here today. So what can be done to improve recruitment? Again, there were two different meta-analyses that I got these results from, or this data from. And one of them was published in 2013, and one of them was published in 2018. The underlined and bolded ideas were from had stronger evidence and were from multiple trials. And then where I have the actual percentages of improvement, that was from the latter study, the 2018 study. So some different strategies that have been shown to be effective are to have an open trial design. So one where people know if it was a clinical trial where people were randomized, they know what they're getting, which of course affects bias, but that was something that did actually impact whether people were willing to participate. Telephone reminders, that made a 6% improvement. The open trial design had a 10% improvement. Information leaflets that were very informed, that again had a significant improvement, but again just a 1% improvement. Paid participation, video presentations, verbal education sessions, framing treatment as potentially faster, telephone eligibility screening, lay advocates, cash incentives, and then potentially text messaging were some other strategies that had some marginal evidence to support effectiveness. So then there was a qualitative study that I thought was pretty interesting, and it looked at factors that impacted participant recruitment and tried to describe those. And they grouped them into 4 categories. So the first one was participant characteristics. So some of the participant characteristics that contributed to recruitment and participants being willing to participate were altruism, paid incentives, beliefs in the benefits of clinical research. The reasons for declining were that they didn't have the time or they were fearful. There were also recruiter characteristics that had a significant impact. So if their usual doctor was the one that approached them about the project or about the study, then they were more willing to participate. Also the knowledge and the clinical knowledge of the person that was coming to or approaching them about participating. So that training of the person that is going to be educating them about the study seems to be important. So also another or main category was this nature of the research, or the risk of the research, whether again if it was open label or they knew what they were going to be getting. And then there was this infrastructure. So the access to participants, collaboration with clinicians, and then increasing public awareness. So I'm going to talk today for the remainder of the talk about this access to participants and then collaboration with clinicians, because from my perspective as a clinical researcher, those are really two key aspects that are definitely a challenge. So how do we actually get to the point of being able to talk to the participant about the study? So those were all things that happen whenever the participant knows about it, but how can we let them know about it? And then also, how is it best to collaborate with clinicians whenever clinicians are a lot of times burnt out and have very limited time? So how can we not put an additional strain on them of, hey, can you go in after you have had to remember the prescription and doing the prior authorization and educating your patient and billing and all these other things that clinicians have to remember. Can you remember to go in and talk to them about this research study? Is that really a feasible expectation of clinicians? And so this is what I'm going to talk about is an option maybe to access participants, but then also not increase clinician burden. Also, increasing public awareness about research was another infrastructure or something else that impacted recruitment from an infrastructure point of view. So, how many of you have had problems accessing the patient population you were interested in when you were having trouble recruiting? How many of you was that an issue? Okay, maybe not for you. It has been for me. Just trying to actually be able to talk to the participants was an issue. So some of the methods that have been used include direct mailings, newspapers, posters, flyers, broadcast advertising like radio, television, word of mouth, social media, online advertisements, email, and then other website promotions. And I'm citing that from a study, and what they were trying to do was estimate the potential costs of these various mechanisms. And the estimated cost per participant recruited was anywhere from $0 to $4,000 depending on the mechanism. So with the web-based mechanisms being a lot more expensive as opposed to like word of mouth, which was nothing clearly. So this can be a very costly endeavor, but when we consider it in the failure of a trial, that has potentially millions of dollars attached to it, obviously it can be very critical. So another option, what I'm going to talk about right now, is using large data sets to access patient populations. So what you will need if you choose to, I'll talk to you a little bit more about what that means, but what you will need if you choose to go down this route is you will need some of the services that are available through the CCTS. So to let you know what those are, you would need the data extraction services, the recruitment services, and the I2B2 query tool, which are all available if you go onto the CCTS webpage and you look under the services and resources and you scroll down to the bottom of the page, these various tabs are there. So, but all three of those will be useful to you as you attempt to use this mechanism. So what happens first? So the first thing that you as a researcher or a research coordinator would need to do is you would need to get IRB approval to use this mechanism. So you're going to have to obtain, you go to the IRB to get approval to obtain a UK healthcare patient list from the Enterprise Data Trust Services for study recruitment. And you can contact Roxanne, and Roxanne will give you wording that is approved by the IRB. But the IRB has to approve that you're going to be using the data trust to access this patient population or identify this patient population. Then you're also going to get IRB approval to utilize the CCTS Enterprise Data Trust and Participant Recruitment Core to contact the UK healthcare patients for study recruitment. And then, like I said, there's examples of the wording that's approved by the IRB for that as well. So the next step is you want to, whenever you go in and you request the services through the CCTS webpage, then you're going to provide your IRB approved letter, and the approval letter and the protocol and then you are going to also have made a letter that will be going to the participants, and so you need to have that ready as well. And then you're going to provide the CTS with the IRB and UK PR approved flyer. So you need to have made a flyer, and then you're going to have this letter. And what's going to happen is that you're going to go and you're going to be able to extract all the patients with a diagnosis from the large data sets, and then a letter is going to be generated, and it's going to go out to all of those people that are identified through the large data set, and then they are able to contact you at that point to determine if they are interested in participating. And these are the steps in doing that. So this is an example of what the letter that Roxanne can provide you with a template. So, and then you fill in your more specific information. But this is just an example of what that letter that potential participants would be getting. And it provides, your contact information and a little bit more about the study. But the letter is actually generated, or the provider on the letter will actually be their provider, or somebody within internal medicine. Sometimes it's Dr. Moliterno. So if you choose to do this, you also need you'll need to identify your patient population through ICD-9 and ICD-10 codes. So again, you are extracting data from the UK healthcare data set, okay? So it's healthcare insurance data. So you have to know what ICD-9 and ICD-10 codes, or potentially CPT codes, you're going to need to extract. Of course, ICD-9 codes are diagnosis codes for specific conditions. I don't remember exactly which year it went from ICD-9 to ICD-10, but if you're looking for older data or a broad spectrum of data, then you might need ICD-9 and ICD-10. ICD-10 codes are much more comprehensive, so you really have to consider there's I think 10,000 codes, so you really have to figure out which one is actually being used for your patient population. So you'll need to figure that out, and then if you want to, let's say, for example, I wanted to do low back pain patients that had undergone physical therapy and had those things billed within their health insurance data, and I wanted to extract all those people. Maybe I wanted to figure out if they felt satisfied with the physical therapy they received, and I wanted to send them a questionnaire, okay? So I can go and I can tell them to extract all the patients with an ICD-10 code with low back pain, and then I can also put the inclusion of them. I want them to have had physical therapy using the CPT code, which is a billing code for a procedure, okay? So, and they can extract those and tell me how many potential participants that are in the data set. Maybe there's 1,000 of them, maybe there's 100 of them, maybe there's just 10 of them. If there's just 10 of them, then maybe I don't want to include the CPT code, and I want to back up and just do low back pain and see if I get people that have had, physical therapy, at some other time or something like that. So anyway, you really have to consider, your ICD-9, ICD-10, and then potentially CPT codes. The large data sets also have information on medications. They have some demographic information, and depending on UK health, what was billed to the insurance companies, so to what is available through UK healthcare. So you might be able. Sometimes you can get some labs. But sometimes the quality of that data can be a little bit variable as well. So you can also use the I2B2 query to kind of get a general idea of whether this is going to be of use to you. So instead of, before you go to all the trouble of getting the data extraction, you can just go on the I2B2 query, which is a way to look through UK Healthcare's data to see how many potential people you might have. You maybe just want to see how many patients have low back pain, just to see if this is going to be a tool that would be of use to you. If you have a very rare condition, then you might need to use a larger data set or try different mechanisms. So let's say you were looking for spinal muscular atrophy, which is a very rare condition that happens to children. We might not see a large enough population of that at UK Healthcare for this mailing tool to be of use to you. You might have to try a different, some sort of more focused recruitment strategy. So what will happen after you contact the data extraction service? You'll provide them with your ICD-9, ICD-10, whatever other inclusion exclusion criteria you want. Maybe you've done the I2B2 query to see whether this is going to be of use to you. Then what's going to happen is they're going to extract those people and tell you, okay, Elizabeth, we found 2,000 people that meet your inclusion criteria. Okay, you've already generated the letter that's going to be going to the participants through the template that Roxanne has provided. You've edited it to be appropriate for your project. You sent it to the IRB with your modification. They've approved it. You have your UK PR approved flyer. The IRB's approved that. So you're going to make a bunch of copies of your flyer, and you're going to provide a bunch of envelopes to Roxanne. And then what's going to happen is that they will they'll generate the flyer and the letter, and they will mail it to the potential participants. So one other thing I wanted to mention about whenever you're extracting the ICD-9 and ICD-10 codes, you might want to or have collaboration with someone that has a lot of clinical expertise in the population that you're wanting to extract the population from, because like I said, there's 10,000 codes. So if you pull a code that is not what clinicians are using, then you're not going to obviously get data or get which the population you're looking for. So I know we did a project where we were looking at total joint arthroplasty in patients that had and transfusions, and so I contacted an orthopedic surgeon to make sure that I was using the CPT code that they use frequently, so that we got the data that we were looking for. So you might have, depending on if there's different nuances to whatever you're looking for, you might have to have a interdisciplinary collaboration just to make sure that you're using the right codes. So anyway, so the Biomedical Informatics Core, they manage the search, and they will access this stored data within UK Healthcare, and then they'll provide the list to the CCTS Participant Recruitment Coordinator. They'll include the demographic information, and the attending physician will be provided with that information, and then they will sign the letter that you provide, and then that letter goes out to the different participants, and then you will hopefully receive information, or you will receive calls based on the flyers and the letters that have been generated. So there is some CCTS costs that apply, and again, you're going to need to provide the color copies and envelopes, and make sure you set aside some time to be able to screen the participants, because again, you're going to have a mailing that maybe goes to thousands of people, so you may need to block off large chunks of time out of your day to be able to screen those people, because you don't want them to actually express interest and then you don't respond to their to their call in a timely fashion. There also kind of be anticipate that there are going to be misdiagnoses, and people that, like, I had a number of people that called. We sent one recently, and it was in their medical record that they actually had that diagnosis, but in fact it ended up that the diagnosis changed over time, and they didn't end up with that diagnosis, and it was never removed from the medical record. And so anyway, there are a few situations like that, and some people call you to tell you that that's the case. So I'm just going to kind of go through a case that we had, a situation where we've used this recently to kind of give it like a living example of how it can be used. So we were conducting a project. We needed to recruit. It was a study where we were developing a scale to measure methotrexate intolerance. It was a 3-phase project, and we had done some qualitative interviews with participants. We developed scale items, and at this point we needed to have 200 patients with rheumatoid arthritis complete our study, or complete the questionnaire to determine its psychometrics. So we needed 200 rheumatoid arthritis patients. We had just done a study where we had recruited 143 rheumatoid arthritis patients. It took us about 2 years to do that. we had been sitting in the clinic, and we had and just waiting for the clinician had approached the participants and then told us, and then we were able to go in and talk to the participants. It worked. Like I said, we got 143 patients from a rare population, but it took 2 years and a lot of perseverance. So we decided to try this, and I'll talk about it at the end, but there were also some growing problems with that old option. So in this particular situation, it was a rare disease, and then the rheumatology clinic was very supportive, but they had outgrown their space, and so we were progressively getting moved further and further away from the patient interaction, which meant that no one was coming to tell us that there was a patient that would be willing to hear about the study. So we started off in the pod with all the healthcare providers. And then as space moved out, then we got moved down the hall, which of course no one was going to walk down the hall to tell us that there was a person. Then we got moved across to the lounge, and so and then I think we got kicked out of there. So there was just no, and it wasn't to be mean. There was no physical space for all the different providers and the patients. So we just, of course, we're in the mix for that. So we really had to come up with some different options to be able to access the population. So that's what we use this mechanism. So we got the IRB to approve our letter. We got the IRB to approve the language that told them what we were going to be doing, and we provided all all those approvals to Roxanne, and then we told the Bioinformatics Core what data we wanted extracted, the ICD-9 and ICD-10 codes, and they extracted those for us, and there were over 2,000 potential participants, and those we provided the color copies and the envelopes from the College of Nursing, and 2,000 letters were sent. So far, that probably transpired maybe 6 weeks ago, and we've screened over 150 participants, and at least 75 of those we have collected data on. And we're still, I'm still getting trickled in calls, and I'm still getting, going through, getting consents back and forth. So it was a fairly robust result from using the mechanism. So in conclusion, using the bioinformatics or large data sets can really be a pretty effective way to access clinical populations. Again, the clinical expertise is needed, so if you need that interdisciplinary contribution, you might want to consider that on the front end, because it makes it really difficult if you go in and they extract the data, and then you come back and you're like, oh, I wish that I had included that they were taking a non-steroidal anti-inflammatory drug, or something else. Oh, I didn't think about that they would need to have not been taking this and this and this. So having that clinical expertise before you extract the data is going to be a lot easier than going back retrospectively. And then again, making sure you block some time to screen, because it took me, it was probably 2 solid weeks of just calling people back and answering phone calls, and considering how are you going to manage those emails, what kind of system are you going to use to make sure you're not dropping an email, and then also your system, do you have a designated phone for your study, or are you just going to be using your own cell phone? How are you going to, all the logistics of managing, those sort of things were just things to kind of consider, and before you have this mass mailing going out to so many different people. But it works really well, and people did not call and they weren't upset. People thought that we had accessed their medical record, because as the investigator, you have no access to the medical record at all. I don't know who was mailed a letter. So in some ways, the IRB only wants you to contact people twice. So if you have 2 or 3 phases to your study, you're only going to be able to contact them twice. So that's something to consider.
Actually, it's not the IRB, it's UK Healthcare.
Okay, UK Healthcare only allows you to contact them twice a year. So that's something to kind of consider if you have a multi-phase trial. and you think that latter recruitment is going to really need a pick up, then you might want to hold off on a second mailing. You do get some of the addresses are not, of course, up to date, so that's something to kind of consider as well. You'll get some, letters back, but I think it's really effective. So, are there questions?